Good morning. My name is Leo Wang, and I'm an associate professor of neurology at the University of Washington, and I'm here today to talk about painful neuropathies. The objective of this talk is to identify the important history and physical exam findings for diagnosing neuropathy as the cause of pain, describe the basic workup for neuropathies, discuss medication management strategies and prognosis for painful neuropathies. So what are the important history and physical exam findings? Questions from history that you should try to elicit include onset, where did it start in terms of the symptoms, duration, whether it's acute, subacute, or chronic, whether it's from days to 4 weeks or 4 weeks to 8 weeks or greater than 8 weeks. That's how we classify in our minds the duration of the disease. And progression, where did it go from? Where did symptoms change to? What did it transform into? Some things that you want to elicit from the history include whether there's motor and or sensory involvement, whether there's weakness or atrophy, burning or stabbing pain, hyperesthesia, allodynia, loss of sensation, numbness, or cold. You can elicit whether it's symmetric or asymmetric, and whether there are autonomic symptoms, such as lightheadedness upon standing, gastroparesis. The question that I usually ask is whether you feel full right after you eat, bowel and bladder problems, erectile dysfunctions, sweating changes, temperature changes in the limbs. And if there's any change in mental status, that definitely changes the differential diagnosis and makes one think of other diseases that involve cognitive changes or systemic diseases. In terms of the rest of the history, in the past medical history, I try to pay attention to whether the patient has diabetes, vasculitis, cancer, or thyroid problems. I definitely pay attention to the medications in terms of trying to elicit medications that could be causes of neuropathy. In terms of family histories, I ask for and pay attention to whether there's history of peripheral neuropathies, foot deformities, or walking problems. If I hear some of those, I try to get more information. In terms of social history, it's important to elicit whether there has been alcohol abuse in the past or currently, and whether there has been any environmental or occupational exposures. In terms of systemic diseases that I pay attention to, once again, is diabetes, critical illness or sepsis, or just being in the ICU is something that can be associated with painful neuropathies and something that one should pay attention to. Cancer, once again, is something that can be associated with a peripheral neuropathy, either the cancer itself, which is probably rare, but more so the treatments. Here's a list of less common systemic diseases as well as rare systemic diseases that can be associated with peripheral neuropathies. In terms of medications, I think that this is an important list to try to elicit and pay attention to. They are important that they've been associated with neuropathies and can cause neuropathies and or neuropathic pain. And intense and probably prolonged exposures to a lot of these would be something that could explain some of the neuropathic pain. The main categories are anti-infectious medications, chemotherapy and anti-cancer medications, anti-rheumatic and immunosuppressants, cardiovascular medications, psychiatric sedatives, as well as other medications. In terms of the anti-infectious medications, the main things that I want to bring out are fluoroquinolones, metronidazole. The HIV medications have been notorious in causing a peripheral neuropathy, and it's something to pay attention to. The side effects of peripheral neuropathy have gotten down, it seems, with the peripheral neuropathy, but it's definitely something that historically and currently is prevalent. Chemotherapies, the main ones are cisplatin, oxaliplatin, taxanes, and vincristine. Bortezomib is a newer medication whose dose-limiting effect is peripheral neuropathy. In the categories of anti-rheumatic immunosuppressants, chloroquine, colchicine are the main ones. TNF-alpha inhibitors seems to be something that has been described recently as the cause of peripheral neuropathy. Cardiovascular medicines include amiodarone. That is not as commonly used these days, but is a cause of neuropathy, probably if one is used intensively and chronically in the intensive care unit. That could be associated with getting neuropathy to its threshold and causing neuropathic pain. Statins is the cause of, it can be the cause of peripheral neuropathies. It has a low incidence, but due to such a prevalent use of the medication, it probably does contribute to peripheral neuropathies. In terms of toxin exposures, here's a list of toxin exposures that one should try to elicit. It's fairly rare that there is enough exposure for a prolonged period of time that could explain peripheral neuropathies, but it's something definitely to keep in mind. What are some findings on exams that you should pay attention to? Whether the mental status is involved, whether cranial nerves involved in terms of motor and what nerve distribution it is, if the pattern is distal and or proximal, if the pattern is symmetric or asymmetric. Reflexes, you're looking mainly for asymmetric drop reflexes. If reflexes are symmetric, it probably doesn't help out that much in your understanding of peripheral neuropathies, except it could just be suggestive that the neuropathy is symmetric. In terms of the sensory exam, you want to look at pinprick, temperature, vibration, and proprioception, and look for gradient. I also pay attention to coordination because that gives you a sense of something that is more involved than just a peripheral nerve, potentially the cerebellar system. Gait is very important in terms of looking at what is the cause of the symptoms. It is also important to assess whether the patient is a fall risk, and that's something that physical therapy can definitely be helpful. One also pays attention to the extremities in terms of looking for atrophy, loss of hair, foot findings or ulcerations in terms of whether they are skin breakdowns, and also whether there is loss of muscle in the foot causing high arches. What are the major neuropathies? I was going to go through a couple of categories of main neuropathies that cause pain, at least in the clinic that we see here at the University of Washington. Alcohol is probably the number 2 cause of neuropathies in the United States. In 107 consecutively examined inpatients, they found that 30% of them had alcohol abuse. They found that 30% of the patients with alcohol abuse had neuropathies. Diabetes is the number 1 cause of neuropathy in the United States. It affects about 8.3 to 8.5% of people in Europe and the United States. Its prevalence of neuropathy in type 1 diabetes patients is about 10 to 54%. In type 2 diabetes, 8% have neuropathy at the time of diagnosis, and overall it's about 1 in 5 patients with diabetes have neuropathy. Idiopathic neuropathy is the largest category that I see in a tertiary care center, mainly because all of the neuropathies that can be attributed to a one main cause are usually diagnosed before they come see me in my neuromuscular subspecialty clinic. Idiopathic neuropathies, or idiopathic, more specifically sensory predominant neuropathies, has a pretty high prevalence. It affects about 2.4% of the population, 8% of patients above the age of 55. It's multifactorial in its cause, meaning that age, genetics, and environmental factors all contribute to this, and I will talk a little bit more about that. Also talk a little bit more about how one should think of idiopathic sensory predominant peripheral neuropathy as the neurodegenerative disease of sensory neurons. Idiopathic sensory predominant peripheral neuropathies can affect large sensory nerves and affect vibration and proprioception, but they can also only affect the small sensory nerves, the small, in terms of small fiber neuropathies. What are small fiber neuropathies? They have at least two of the following symptoms. They have either neuropathic pain, a normal nerve conduction study, or reduced intraepidural nerve fiber density at the ankle, or abnormal quantitative sensory testing in terms of the thermal thresholds at the foot. In terms of neuropathic pain and other symptoms, they include burning, shooting, or itching kind of pain. They have hyperalgesia in terms of sheet or sock intolerance. This seems to be something that patients experience when they go to bed. They have restless leg syndromes, autonomic dysfunction, clinical signs of small fiber damage, such as pinprick loss on exam, thermal sensory loss, allodynia, or hyperalgesia. In a review of symptoms, one finds these following symptoms and these following examination findings as prevalent. In the category of definite small fiber neuropathy, 60 to 64% of patients had burning and tingling. Less so had pins and needles sensation, but then there were also some that had itching. A lot of patients complain of numbness, stabbing, and shooting pain, but probably less so. They describe it in a length-dependent manner, meaning that the most distal parts were affected most, and then it progressed proximally in about 100%. A lot of them don't describe episodic. However, if you talk to patients, a lot of them seem to get worse when they relax and they can pay attention to their symptoms, either when they come home from work and sitting at the couch or when they're going to sleep, and that seems to be a clear disturbance of their quality of life. In this review of symptoms, it is not worse with walking. In terms of the examination findings, the main ones were diminished toe vibration, which is a large fiber modality, diminished pinprick in the toes and feet, as well as diminished temperature in the toes. Allodynia and hyperalgesia were some findings that they were able to elicit. So what is the loss of small fiber neuropathies? Small fibers, so it is the loss of the intraepidermal nerve fiber layer. So the distinction is between the dermis and the epidermis, and here are the small nerve fibers that penetrate through into the epidermis. And this is the loss of the small fiber neuropathies, small fibers, and you can see that there is a loss in that layer. And idiopathic painful neuropathies are probably a neurodegenerative disease of the sensory neurons. And I like to just make a couple of comparisons to make this point. Here is a brain MRI. On the left is a brain MRI of somebody who's healthy in their 20s, and here is one of an older person. And you can see that there's been loss of neurons, and that seems to be something that is prevalent throughout the nervous system. It occurs in the brain, the spinal cord, as well as the peripheral nerves. When you have Alzheimer's disease, the main factor seems to be age, but also genes contribute to it. In terms of these genes on the left here, that are autosomal dominant causes of Alzheimer's disease. You can have genetic modifiers that change the duration or the onset of the disease. In terms of environmental factors, keeping active, such as bilingualism, is protective. What is not protective is probably diabetes as well as vascular events. Hearing loss, which I think is a good parallel to the sensory loss that one gets in peripheral nerves, is also dependent on age. There are genes that can affect it and cause them in a autosomal dominant or recessive fashion, as well as genetic modifiers. In terms of environmental, what is protective is ear protective devices, but what is not protective is noise exposure, especially in the veteran population. Smoking is not protective, as well as ototoxic medications such as aminoglycosides. We find these factors, age, genes, and environment, to be also similar in the small fiber neuropathy population. Age, once again, we talked about, is something that's a main contributor to the cause of small fiber neuropathy. Genetic causes include those on the left. 3 of the sodium channels can cause episodic pain or painful neuropathies when mutated, as well as this TRPA1 gene. Modifiers that are genetic include the Charcot-Marie-Tooth genes. In terms of what is protective and non-protective, keeping active, having healthy exercises is protective. What is not protective is trauma, ICU stay, diabetic or glucose intolerance, alcohol, fluoroquinolones, and chemotherapies. These are part of the environment, things that are intrinsic to our body that can cause and contribute to small fiber neuropathy. In terms of the age aspect, you can see here in this graph that on the y-axis is epidermal nerve fiber densities of the leg, and on the x-axis is age. And you can see that as we age, there is loss of epidermal nerve fiber density, similar to the MRI I showed, and so there seems to be a loss of that. If you graph out the number of neurons, and this is a hypothetical graph, you can see that as we age, there is a decrease in the number of neurons. Genetics probably influence the slope of how fast we lose the number of neurons, and when it gets to a threshold here by the dashed blue bar on the graph, it tells us that's probably when you reach a symptomatic threshold and you start experiencing pain. Environmental factors such as being involved in a trauma or in a critical illness can cause a quantal decrease in the number of neurons and hasten the progression towards a symptomatic threshold. These seem to add up in terms of the genetics and environmental factors, and therefore exposure to, say, a neuropathic agent, causing agent in the past could contribute to it, but it's probably just the accumulation of environmental factors over time, as well as age, that makes one reach a symptomatic threshold. So there's a contribution of the age, genetics, and environmental factors. What is the basic workup for neuropathies? In terms of what lab tests should a primary care physician do, these are some recommendations from the American Academy of Neurology practice guidelines. Serum vitamin B12 levels with metabolites. This includes methylmalonic acid with or without homocysteine. Should be something that one obtains. Serum immunofixation or serum protein electrophoresis. Blood glucose and hemoglobin A1C, and the American Academy of Neurology recommends getting a 2-hour glucose tolerance test. A lot of times physicians think that if the hemoglobin A1C is normal, that precludes one from developing diabetic related peripheral neuropathies, but it seems as though it's the amount of exposure of glucose to the peripheral nerves that causes a association with peripheral neuropathy, and therefore the inability to uptake glucose from the blood in a rapid fashion in terms of exposures of glucose to nerves for a prolonged period of time, because the body can't take it up into the liver or the muscle, probably coats the nerves and causes nerve damage. Serum immunofixation and serum protein electrophoresis is important in that it allows us to increase our surveillance for monoclonal gammopathies, as those have a reasonable rate of conversion to multiple myeloma. What are the red flags of neuropathy? What are some signs of neuropathies that one should pay particular attention to and seriously consider the referral to neurology? And here's a list of them. It would be asymmetry, whether it does not follow a length-dependent pattern historically by symptoms or on exam, whether it involves proximal nerves, whether it involves the motor component, autonomic component, and whether it's acute. And even if it's just numbness, tingling, and pain, if it's acute, it's probably a different disease than the idiopathic sensory predominant peripheral neuropathies. And these are the ones in which one should seek the help of neurology, and it also needs EMG nerve conduction studies. What are some medication management strategies for neuropathies? Here are some of the ones where you can use to treat painful peripheral neuropathies. Anticonvulsants were used mainly for seizures, but now have been found to be beneficial for treating peripheral neuropathies. These include pregabalin, gabapentin, and sodium valproic. The serotonin and norepinephrine uptake inhibitors are also helpful: amitriptyline, nortriptyline, venlafaxine, and duloxetine. Opioids should be very much rarely used, since they are a gateway to opioid dependence and abuse, but there may be some role in very, very rare patients. Capsaicin, isosorbide dinitrate, electrical stimulation, and percutaneous nerve stimulation have been found to be helpful, but the study only looked at very short-term treatments of 3 to 4 weeks. There are also creams that, for very localized pain, could be helpful and have been useful. Amitriptyline, ketamine, ointment, and cream is something to consider. I'm going to go through a couple of these medications and discuss the evidence for them. Gabapentin and gabapentinoids are medications that bind to the alpha-2 delta subunit of presynaptic voltage-dependent calcium channels. This medication is good in that it does not bind plasma proteins and it does not induce hepatic enzymes. It's excreted unchanged in urine. It has a short half-life, and therefore one can get benefit probably from more frequent dosing. In terms of the frequency of dosing, sometimes you have to get up to 4 to 5 times. In terms of the evidence in diabetic neuropathy, there's been a randomized placebo-controlled trial over 8 weeks, including 165 patients. The mean daily pain score was lower with gabapentin, and that difference was significant. There was 26% of the patients were pain-free versus 15% on placebo, and there was an improved quality of life and sleep. Amitriptyline and tricyclic antidepressants are serotonin and norepinephrine reuptake inhibitors. They have the side effects of somnolence, dry mouth, constipation, lethargy, insomnia, uneasiness, and dizziness. These symptoms could be helpful in patients who have insomnia, and something to consider. The fact that they have more of a norepinephrine reuptake inhibitor qualities that make them more effective than SSRIs, than selective serotonin reuptake inhibitors. In terms of amitriptyline versus other medications, if you compare it to gabapentin, there's no significant difference in the crossover study for diabetic peripheral neuropathy. For duloxetine, both duloxetine and amitriptyline demonstrated similar efficacy. Let's talk a little bit more about duloxetine. Duloxetine is a selective norepinephrine reuptake inhibitor. It has adverse effects that are dose-dependent, including the very similar ones to the ones we just talked about with the tricyclic antidepressants. These include nausea, somnolence, dizziness, constipation, and dry mouth. They have drug interactions with monoamine oxidase inhibitors, other tricyclic antidepressants, phenothiazine, type 1C antiarrhythmics, quinolone, antibiotics, and cimetidine, and therefore one needs to pay attention to those drug interactions. One should be cautious in using them in closed-angle glaucomas as well as hepatotoxicity. There's a black box warning in terms of they can have a suicide risk. In a study that looked at duloxetine in a randomized multicenter trial for the management of diabetic peripheral neuropathic pain, there was a change. You can see a floor effect, which seems to be something that's pretty consistent in all the studies, of a decrease in 3 points on the Likert scale of pain over a 10-point scale. You can see that over about 12 weeks that the placebo arm did have a decrease in the amount of pain, as is what we find quite common in these types of studies. But the treatment with 60 milligrams daily or 60 milligrams BID of duloxetine decreased the pain significantly by about 3 points. There does not seem to be a difference between 60 milligrams daily versus 60 milligrams twice a day. Another study, also looking at diabetic neuropathy, also found something very similar in terms of decrease in 3 points. As opposed to the prior study, there seemed to be some change in difference between 60 milligrams once daily and 60 milligrams twice daily. This was most likely involving more side effects. Venlafaxine is another selective norepinephrine reuptake inhibitor, and it also decreases pain about 3 points. And you can see here, compared to placebo, having venlafaxine extended release at the 150 milligrams to 225 milligrams twice a day is probably more. 150 milligrams, 225 milligrams per day in a BID dosing probably was more helpful than the placebo arm, and it's definitely something to consider to use in your armamentarium. A little bit more about the gabapentinoids and pregabalin. I don't use this as much, mainly because it is a scheduled FDA medication, and there is some inconvenience to using it, but there definitely is some evidence for it. It's similar to gabapentin. It binds to alpha-2 delta subunits of the presynaptic voltage-dependent calcium channels. It has adverse effects of dizziness, somnolence, peripheral edema, which is something that I've encountered a few times, weight gain, dry mouth, and blurry vision. It also has a serious adverse effect of a suicide risk. Here's the data for pregabalin in painful diabetic neuropathy. There seems to be, once again, you can see about a 3-point change in the mean pain score about over 5 weeks, and that seems to have a ceiling effect around 300 milligrams per day. However, there are some studies that show that patients could benefit from higher doses, but probably pushing it up furthermore is not really helpful. In terms of comparison, the percentages of patients was 50% reduction in average daily pain score. A study compared pregabalin, gabapentin, and duloxetine. This is their daily doses. And in terms of the percentage of patients that achieved greater than 50% pain relief, it was about 40%, about similar for all three medications. And the number to treat was about 5 to 6. So it took there's 1 out of every 5 patients that probably is able to achieve a 50% reduction in the average daily pain score. In terms of the percentage of patients who withdrew from adverse events, you can see there, it's not a low percentage, but it's definitely not a high percentage. And it's definitely something that can cause patients to withdraw from the medications. Here's something that I think about when I'm confronted with a patient that needs neuropathic pain medication. I usually start by trying to decide whether the patient needs gabapentin, amitriptyline, or duloxetine. Think about amitriptyline quite a bit because of its very good interaction profile as well as its side effect profile. Amitriptyline is something that I use in patients who complain of insomnia, but it's definitely medication that I try to avoid in the elderly. It's definitely something that can be used, but it tends to affect the elderly more. Duloxetine is something that I think about if I don't want to cause as many side effects as amitriptyline in terms of the beneficial side effects, in terms of insomnia. But I think that's a medication that would benefit the patient. The second line would be to switch it around and consider switching to gabapentin if they're on the other medications, amitriptyline, duloxetine, venlafaxine, or pregabalin. There seems to be some evidence that the combination of duloxetine and pregabalin could be more beneficial. That's definitely something that could be helpful, but a lot of times patients start to accumulate side effects, and it is insidious and not very obvious, and pretty soon it becomes very precarious with the addition of another medication. Patients complain of brain fogginess that improves once you simplify the polypharmacy. Here's a set of medications that are not recommended: carbazepine, lamotrigine, lacosamine, clonidine, pentoxifilling. Opioids is something that we try to avoid, and there is a recent article in JAMA Neurology that talks about how opioids do not have a good outcome in terms of functional status and mortality in patients with polyneuropathy. Magnetic field treatment, low intensity laser therapy, which is something that we see a lot discussed in the Seattle, Puget Sound area. Reiki therapy, which is a good way to describe it, would be a non-invasive massage therapy. These have all been studied and not found to be particularly beneficial. In terms of what can be tried, alpha-lipoic acid was found to be helpful as a supplement that one can get in over-the-counter in supplement stores. It was tried in German populations with diabetic neuropathy and appeared to help. Mixilotine is a medication that has been reappropriated to be used for cramps. It has some really good evidence that it's helpful for cramps. If patients have the predominant symptoms of cramps, this is something that could be helpful for them. Acupuncture, exercise, and cognitive behavioral therapy have been things that have been tried and been successful. What to expect in painful neuropathy, looking at the prognosis of these painful neuropathies and these neuropathies over time. There have been studies that looked at 12 and a half months, 18 months, 3 years, and 5 years in various different places. The studies look at it in the United States, Australia, as well as Europe. And you can see that they do tend to worsen a little bit over time. It is worse. It worsens and increases about 15% to 33% by 18 months. And this worsening is in terms of symptom expansion as well as worsening of the intensity of symptoms. You can see that there hasn't been many patients that needed assistive devices over time, but there is some after a very prolonged period of time, in 5 years. But most of them have other concomitant diseases and comorbidities that probably contribute significantly to needing assistive devices. So I think that the things that we covered today in our short amount of time together is to identify the important history and physical exam findings for diagnosing neuropathy as a cause of pain. I described a basic workup for neuropathies, described medication management, as well as prognosis for painful neuropathies. Hopefully this has been a quick and short review in a nutshell of how one should approach painful neuropathies. Thank you for your attention and have a good day.